I'll cover this topic in the next maybe some 25 to 30 minutes under these subheadings. What is an ASCD? What is the burden of sudden cardiac death in the community? And what are the categories of patients are at risk for sudden cardiac death? And the clinical subgroups that may benefit from ASCD with some evidence and illustrative examples. I have been instructed not to add many trials, and most of the attendees are primarily very experienced physicians. So it should be somewhere in between, incorporating very senior physicians as well as cardiologists. So I'll try to uh, go according to that instruction. Here is a 30-year-old lady with two episodes of resuscitated sudden cardiac death. The QTC was normal even on provocation. That is, these patients, when they come with a structurally normal heart and without any provocation, they develop sudden cardiac arrest. And you document that rarely happens in short coupled states like this. And your underlying condition, underlying QT is normal even after provocation. It's called short coupled variant of polymorphic VT. It's an extremely uncommon form of channelopathy, but genetic mutations have been identified that can lead on to this short coupled variant of polymorphic VT. It was called idiopathic VF in the past. When this patient comes to you and you have limited options regarding treatment, and you may have to, because they are so episodic, unexpected, so sporadic, so you won't be able to take any major therapeutic preventive action or therapeutic or preventive action other than ICD. And ICD helps when these events happen to shock and bring them back to life, identify the ventricular fibrillation, that sense ventricular fibrillation, and defibrillate these patients so promptly. Let us see what happened to this case. A few months after the implant, this patient again had another episode. You can see the short coupled event happening there. And this patient had was detected to was not correctly identified, appropriately recognized to have ventricular fibrillation. You can see the cycle length 180, 130, 180, 184 NL, which corresponds to more than 300 beats per minute. And this was identified and defibrillated. This high voltage therapy, 36 joule given, and the patient is brought back to normal sinus rhythm. So this is the essential function of ASCD. Many people ask when they get when we advise them to have an ASCD, what are the disadvantages? Can I have hematoma? Can I have inappropriate shock? Can I have to carry? So many questions, all those things. But the essential question, the essential message I convey to them is that it actually just got a lot of disadvantage. But one advantage takes care of everything. Yagopi dosho gunasannipade nivajjata. That is what Kalidasa said. If you have a wonderful one major advantage, that is essentially that saves your life. So that is the this case exemplifies that very well. ICD, what are the functions? What are the components of this ICD as well? You will see. This is the pulse generator, and you also have two leads, one implanted into the atrium and other to the ventricle. So it acts as a pacemaker plus. It has got a pacemaker function. In addition, it has got a function to sense ventricular fibrillation or ventricular arrhythmia and treat them either with anti-tachycardia pacing, cardioversion, or defibrillation. So basically defibrillation together, anti-tachycardia pacing and bradycardia sensing and pacing. So it can sense and pace like any other pacemaker. In addition, it can give an anti-tachycardia pacing, and also it can shock the patient. Of course, some of the newer models can have anti-tachycardia pacing in the atrial as well as some atrial arrhythmia prevention strategies, which is there for some of the pacemakers as well. The thing is that the battery, this has got a 3.2 volt and it can generate up to 80 volt, and you have to shock up to 36 to 40 joule when you get an event within a very short time. Within probably 10 to 12 seconds, you have to build up that energy and deliver. And you need to have a capacitor, you have a battery, these are the components, and a complex circuitry as well. So how does it recognize the ventricular fibrillation or ventricular arrhythmia? It is called bipolar sensing. Why is it relevant? Many times people ask whether they can do this, remove the tooth or apply a cautery far away from the pacemaker and all those things. Ideally, this bipolar sensing should sense electrograms only within this closed circuit. Normal pacemakers can have either bipolar or unipolar sensing, essentially meaning that your cathode is here and this can the pulse generator access the other pole and sensing happens between them. But ICD, it is a strong no. It happens only between these. You cannot program an ICD into unipolar, and this is actually a bipolar sensing pattern. And you can also have something like an integrated bipolar, but that is, basically, if you have a coil here and this RV coil, and this can have a sensing vector, but essentially, most of the time, the primary approach is to have a bipolar sensing pattern, and the recognition of these events can come only between them. Or if you have a break in the lead, sometimes this can be sensed as an electrical noise. Otherwise, far field is unlikely to happen unless you have some electromagnetic interference, which also comes in this field. So it sends appropriate cardiac signals. We know that is essence to that is the most important thing is sensing and pacing in the Brady fashion, like any other pacemaker. And it detects dangerous rhythms reliably, like ventricular fibrillation comes, ventricular tachycardia comes, and it provides pacing and defibrillation therapy. ATP here, defibrillation therapy is shock. And also it stores diagnostics so that one can assess it later on. Here, regarding sensing, the most important function of an ICD is probably sensing, because if you don't sense it properly, you can have two problems. One, if you oversense some of the things outside, that is like some noise, as I mentioned, or electromagnetic interference, then you recognize them as ventricular fibrillation or ventricular tachycardia and give inappropriate shocks. This happens if the patient lead gets a fracture or due to certain other reasons. Similarly, if you don't recognize ventricular fibrillation due to some reasons, actually this patient can continue to have ventricular fibrillation going on and you don't shock at all. So this is another problem with the ICD. So how does an ICD recognize these things? So it has recognized each electrical signal being sensed at bipolar sensing mode. That's very close proximity between tip and the ring. With each RR interval is classified. So based upon the interval, it recognizes as when sinus rhythm. If it falls into a faster zone, it recognizes as a VT. Still faster, it recognizes VF. How fast is fast? You can put it like this: 50 to 150 is sinus, 150 is 200 is VT, VF more than 200. We call it as 3-zone programming and 2-zone therapy. VT zone you program as therapy, and this also you put it as therapy. So these are all converted into intervals. That is the way it recognizes. Like 200 comes to 300 milliseconds. It is actually beats per minute. 1 minute is equal to 60 seconds, and 60 seconds is equal to 60,000 milliseconds. So 200, it comes to 300 milliseconds. That is the way it is converted. So 120 to 300 here, 400, 1200 comes to 50 beats per minute, and 400 comes to 150 beats per minute. So here 50 to 150 is classified as sinus, because even if it is between 100 and 150, you have got a VT, this would recognize as a sinus only. That is the, some disadvantage is there in this, but that is very important to avoid unnecessary shocks during exercise, etc. So this will be recognized as V sense, tachycardia sense, and this fibrillation sense, let us say. And beyond that, it also depends how many intervals we need to find out. If you have an ectopic, still it would fall into this 240 milliseconds or 360 milliseconds interval. But you also need to have number needed to detect. This is 16 in this case. For redetection, it is 12. So number needed to detect, and at the duration of the interval, that is the way a tachycardia is defined here. So you can see that in the window on the right side. So number needed to that number of intervals detected needed to detect is 16. NID number of intervals to detect is 16. So the detection of is made here, and then it goes to therapy. So once it senses it as a brady, it stimulates like in any other pacemaker. Once it recognizes a VT, it should be an anti-tachycardia pacing or cardioversion. Anti-tachycardic pacing can be burst at regular intervals, like a burst pacing, dry cycle length or something. If you make it something like a 300 milliseconds, 200 beats per minute, it actually paces at 200 beats per minute for a finite intervals. Ramp, there is a continuous reduction in the coupling interval. There are two ways of pacing it. Then the fast VT detection and the VF detection and defibrillation. Here the anti-tachycardia pacing, you have a rate of around cycle length of around 440, 460. So it is pacing at a 360 or 370 slightly faster so that it captures the myocardium and it overdrives the tachycardia and then it terminates the tachycardia. So there are different types, burst and ramp. The importance is that it avoids shocks. Many tachycardia or high rate events can be subjected to ATP, anti-tachycardia pacing, and can be terminated. So it's actually pain-free therapy as compared to shock, which is often painful. Here you can see a tachycardia fibrillatory range. It comes 310 to 40 to 10. Then the ventricular fibrillation is detected and a shock is given. So here again, that is back to sinus rhythm. Sometimes this ATP may not be successful. Here you can see the VT onset. This anti-tachycardia pacing comes in, and here the tachycardia goes on, and it actually accelerates, and then it goes into fibrillatory zone. You can see it's recorded as FIB, and a shock is given, and it terminates the tachycardia. This is one of the complications that can happen with ATP. It accelerates the tachycardia and ends up in giving shock. As in this case, which we showed initially, it goes now. You can see the F here, that is fibrillation. Then it's a fast. The cycle length is noted here. It detects, and after detection, ATP during charging, then it actually gives shock and high voltage shock here, and it comes back to sinus rhythm. So this is regarding the function of ICD as such, and we will go to what is sudden cardiac death. Sudden cardiac death, it has got variable definitions, but broadly it can be defined as a cardiac death within 1 hour of onset of symptoms when the death is witnessed, or within 24 hours of being seen alive and well when it is unwitnessed or that occurs during sleep. So this 1 hour definition refers to the period between onset and terminal event and cardiac arrest. This is a broad definition because even if it is slightly higher or some of them are not witnessed, we will have to consider it as sudden death, and most of the sudden deaths happen due to cardiac causes, and often the etiology may not be obvious at that point in time, and we need a clinical evaluation, clinical in the sense verbal autopsy and also pathological autopsy to recognize, especially if it happens without any premorbid problems. The magnitude of the problem is quite high. If you take the sudden death as per the definition I described, almost 1/5 of deaths happening in 20 to 75 years is sudden death, and the incidence comes to the tune of 1 to 9 per 1 lakh person years. The importance is that the structural heart disease accounts for significant proportion of these patients in young victims and the commonest cause is premature CAD even in young. But as the age advances, the proportion of patients doing SCD due to coronary artery disease increases, and the proportion of other cardiac causes will have lesser importance, whether it be hypertrophic cardiomyopathy or other cardiomyopathies or channelopathy. That's why if you see the SCD risk for hypertrophic cardiomyopathy, as the age advances, the SCD risk given for age comes down. So as the age advances, the structural heart disease contribution, apart from coronary artery disease, comes down. CAD can be labeled as a separate form of structural heart disease rather. So SCD contributed to 10% of overall mortality in this patient in this population in a study published by Dr. Hagri Rao. It's a population-based study, but detection of causes was made by verbal autopsy and also from the records available in the corporation. And when that group aged less than 50 years of age was compared to aged 50 years of more, the prevalence of definite CAD and major risk factors for SCD was similar. Probably South Asian population has got very high risk of CAD, but the proportion of patients with the hypertrophic or cardiomyopathy, other dilated cardiomyopathy, genetic cardiomyopathy, and channelopathy is also quite high in this population, as evidence comes out from many registries across the country. But so if you see the age distribution, most of these SCDs happen between the age of 50 to 70 years, and it's important to address the causes in this population. And also, if you see the young patients less than 40 years, the CAD still dominate, but there are certain subgroup like unknown causes where you have a negative pathological autopsy. It could be contributed by conditions where you can have genetic arrhythmias in structurally normal heart like channelopathies. But certain other studies have shown hypertrophic cardiomyopathy as the dominant cause. But so there is a regional difference as far as the SCD risk is concerned. But I think this is more or less fine. 80% of the SCDs are related to CAD, and 10 to 15% is related to cardiomyopathy, and almost 5% of them related to conditions that we are not sure where you have any objective, we don't have any objective evidence of any structural heart disease or definite evidence of CAD that could be due to conditions like channelopathy and other, I mean, of course, genetic cardiac arrhythmia syndrome. And sudden cardiac death, ventricular arrhythmias account for most of the cases, as of course, it's 88% arrhythmia because ventricular tachycardia, 62% ventricular fibrillation, and some of them could be related to bradyarrhythmias or polymorphic VT, I mean, like what we have seen. But another interesting point regarding the distribution, the landscape of sudden cardiac death is that if you take the large, the population into account and look into the conditions that can put them under risk of sudden cardiac death, you have conditions like less than 35% in congestive heart failure, sudden cardiac arrest survivor, high risk post-MI subgroups with a low ejection fraction. They are all at very high risk to have a repeat event in sudden cardiac death. But if you take the large population, those patients, normal, otherwise labeled as normal persons, have statistically, they contribute to the highest number in population. If I can put a corollary, if you go to a police station and find out a crime has happened under that police station, and you look what is the most likely cause for this person, it must be a person who has committed the crime for the first time, unsuspected person. But if you ask the police, they always see the persons who had done a crime, they are more likely to repeat it in future. Something similar to that. In a population large landscape, normal people, general adult population contribute statistically more to SCDs. But if you see proportion wise in every subgroup, patients with ejection fraction less than 35%, survivor of SCD or high risk post-MI, they have the highest propensity to cause sudden cardiac death. And in this population, ASCD has got an important role. And people have shown studies based upon ASCD, HEP, TAVID, SITS, CASH, the classical secondary prevention studies, and the MADIT, MUST, and MADIT 2, the classical primary prevention trials. They all had shown significant reduction benefit of SCD in this population. And sudden cardiac death and heart failure, they also have a close association. The CHF patients are very high risk to develop sudden cardiac death, and the proportion of this patient sudden cardiac death accounts for significant number of deaths as compared to other causes in patients with the post-MI and LV dysfunction as well. And as I mentioned, the paradox occur here also. If you see this LV EF minus CD, almost 44% of the events happen in less than 30%, but 56% happened in LV ejection fraction more than 30%. So this is anyway the paradox that is related to the reasons I mentioned above. And in each of these subgroups, irrespective of what ICD has decreased the mortality. And in fact, primary prevention trials, the benefit is equal or greater than secondary prevention trials. You can see what is labeled as orange or orange here is arrhythmic risk reduction and the overall risk reductions otherwise. So MADIT must and MADIT 2, the primary prevention trials had equal or more risk reduction compared to secondary prevention trials. So I'll come to the third part of my talk. It's based upon what are the evidences available in each subcategory. And I will also add up a few illustrative cases. And these are the references that one can go through if you want to learn more about evidence in sudden cardiac death and ICD. There is a patient, a 71-year-old male, a diabetic, hypertensive, class 2 for 2 years, intermittent episodes of palpitation. This patient had a normal echo, normal LV function, and normal ECG, while a lymph node biopsy for suspected tuberculosis was done. Ejection fraction now it's 42%, global LV hypokinesia, mild pH, and class 2. This patient had incomplete, primarily this PR interval was 240 and incomplete LBVB at baseline. Then also had ventricular tachycardia, documented VT you can see. And what should be the next management? You have a patient with a structural heart disease. You have all the options. Of course, you have to evaluate these cases before you label as non-ischemic or ischemic cardiomyopathy. So we took this patient for further evaluation. Coronary angio was normal. That categorized this patient as a non-ischemic cardiomyopathy and elderly male non-ischemic cardiomyopathy. Documented stable and sustained VT, sinus rhythm, conduction system disease, no other major comorbidities. So as per the definition, this falls into class 1 recommendation, with a level of evidence coming as B from non-randomized studies, that is in patients with a non-ischemic cardiomyopathy who either survive SCA due to VT or VF or experience hemodynamically unstable VT. Both of them, this evidence is from randomized. Or if they have a stable, sustained VT, like our case, the evidence is from non-randomized studies, not due to reversible causes. An ICD is recommended if meaningful survival greater than 1 year is expected. All the recommendations in ICD, one thing is common. That is, if meaningful survival greater than 1 year is expected. Because none of these studies had significant number of very sick patients, class 4 patients expected to have limited longevity, severe comorbid problems. They were not included. It's every patient, every subgroup, this is a meaningful adjuvant. That is, if we have a meaningful survival greater than 1 year is expected, then only ICD is to be considered. There is no such recommendation for CRT. One should remember that. Here, we need to look at those clauses, reversible causes, whether non-ischemic dialytic cardiomyopathy are the definable etiologies. So this patient had a MANTO negative, ACE levels mildly elevated, had shown an LG focal areas of subendocardial enhancement in basal lateral level of LV. For sarcoidosis, the more characteristic one is subepicardial or basal septal locations, but overall features and also CT that showed multiple lymph nodes in pretracheal, prevascular region, AP window, and bilateral hilar regions, and not a sub-centimeter, it's more than 1 centimeter. All these suggested this patient had features suggestive of sarcoidosis, and this was confirmed from a skin lesion. And we did an EP study. It had shown a prolonged HV interval, AV piggybacking at 500 milliseconds. So we did a PET and followed by CRTD and started on steroids and methotrexate. Patient did not have any ICD shocks in the last 7 years. LVEF improved to 50%. So whether this patient I really required an ICD? Of course, when you put an ICD, we know it is not going to shock this patient every case. I generally tell this patient, if you get a shock, that is good because you required it and his life was saved. If you don't get a shock, fine. You never required it. That is the best thing. So it's like insurance. Like if you need it, it's good. If of course it is not good. If you don't need it, that is much better. So like the evidence on secondary prevention trials is from classical trials like AVID, 6 and CASH. Altogether, they had more than almost 2,000 patients, and AVID dominated the number wise. And most of the meta-analysis on this are dominated by the AVID, which had contributed more than half of these total numbers. And all these cases, aborted cardiac arrest or syncope or aborted cardiac arrest, all these things, the level hazard ratio was highly favorable when you have a ICD in, but only 15% of the patients had non-ischemic cardiomyopathy, and that is an underrepresented one. But in this case, we went ahead with the ICD, and this patient is has LV function has improved. That is when you stratify this non-ischemic cardiomyopathy, in addition to this AVID SIDS-CASH era, we have additional modalities like genotyping and cardiac MRI coming up now, contributing a lot. We have a lot of understanding on this, and the indications for ICD in this recommendation, actually they have included non-ischemic cardiomyopathy, other causes which may require ICD beyond the classical recommendations based upon the classical trials. They have included long QT syndrome as in the non-ischemic cardiomyopathy, which is truly a channelopathy, but that simply shows the heterogeneity of in the population of non-ischemic cardiomyopathy, which could be a sarcoidosis, a reversible condition, hypertrophic cardiomyopathy, which is probably a progressive in many, but not a reversible condition, long QT, then laminin-like cardiomyopathies, which have got a high propensity to develop conduction system problem and ventricular tachycardia, ARVC, grown-up congenital heart disease. All these things, each case we have to individualize the treatment and decide on ICD. This is a case to a 45-year-old female, history of carcinoma of breast treated in 2010. Adriamycin-induced cardiomyopathy very clearly. LV ejection fraction 32%. LV end systolic dimension is 58 millimeter, which is quite high. General upper limit should be somewhere around 28 millimeter from 40 millimeter maybe. So it is significantly dilated LV. Coronary is normal. ECG QRS is normal. Class 3 NT-proBNP 2340 picogram per ml. Should we recommend ICD for this case? The recommendation is that in patients with a non-ischemic cardiomyopathy, heart failure with the class 2 or class 3 symptoms and EF of 35% or less, despite GDMT, an ICD is recommended if meaningful survival greater than 1 year is expected. So here we have a patient with ejection fraction less than 35%, NYHA class 3 and non-ischemic cardiomyopathy and heart failure. So it is indicated in class 2 and 3 despite GDMT for at least 3 months. All these trials have shown it clearly. They significantly reduced the all-cause mortality except Danish that resulted in 50% relative reduction in SCD. All-cause mortality was not reduced. So this is the odds ratio favoring ICD. And in class 1 patients, as I mentioned, class 1 patients are also underrepresented in the studies, and it's uncertain whether a primary prevention ICD is beneficial in non-ischemic cardiomyopathy. In fact, definite trial had only 20% patients in the class 1 heart failure, but in class 4, there is again insufficient data regarding the value of ICD, as I mentioned, because of the reasons like these sick patients had not been included, and now actually some of these sick patients had received an additional CRT also, and so it's difficult to accumulate data in this subgroup. So we are dealing with the patient ischemic cardiomyopathy primary prevention, ischemic cardiomyopathy secondary prevention, non-ischemic cardiomyopathy secondary prevention, and non-ischemic cardiomyopathy primary prevention. The third and fourth subgroup we have completed. Now we will come to the third and fourth subgroup. This is a patient who has got a ICD, who has come with a history of ventricular MI in the past, had a PCI, ejection fraction 40%, syncope, multiple drugs, and had a pacemaker in the past for CHB, normal pacemaker function, coming with syncope, heart normal. What next? This patient, as I mentioned by Dr. Jaishankar, if the patient, a patient with a structural heart disease has wide complex tachycardia, it has to be considered as VT. Here there was no documented tachycardia, had history of recurrent syncope. The question is whether syncope can be considered as a primary prevention or secondary prevention. What is the most reasonable next step in the management? We can upgrade the device directly to ICD without further evaluation, repeat coronary angiogram, of course it has to be done, modify the medications, and plan EP study. So this patient, how to evaluate for syncope? As in any other case, in this case as well, you have to evaluate for ischemia and also get a lead ECG, echo, ambulatory ECG monitoring, TIT table test if the condition demands, event recorders, ILRs, pacemaker diagnostics you can get through electrophysiological study. This patient had an angiogram which showed patent stent. VT study showed inducible polymorphic VT on triple extra, which is actually non-specific like this. So this cannot be considered as an inducible ventricular tachycardia as per the standard definition. Vasodilators reduced, diuretic stopped and kept on follow-up. This patient eventually had another episode and admitted in CCU, had a sustained ventricular tachycardia, and this patient had an ICD afterwards. This belongs to secondary prevention trial. The classical avid sits cash. Most of them had ischemic cardiomyopathy as a substrate. Altogether, more than 2,000 patients, follow-up of 3 years, and the overall mortality, arrhythmic death has come down significantly in this all subgroup. So when you consider these patients, there are confounding factors, whether transient or reversible factor, like a AMI, acute myocardial infarction, proarrhythmic medication, electrolyte disturbances, and ICD is not implanted if the cause was not correctable. Still, it requires thorough evaluation, treatment, and close follow-up. Small increase in troponin could be related to cardioversion. At times, it is difficult to determine whether the elevation is due to ischemia or resuscitation. Those, if it is small elevation, at ICD is likely warranted unless you prove it is related to ischemia-related VT, which is often polymorphic. Monomorphic VT is less likely to happen in a ischemia-related arrhythmia is less likely to be a monomorphic VT. Pre-existing scar reduction in the arrhythmia threshold due to ischemia can happen, but otherwise, an indication that ischemia caused arrhythmia is present, prevention of ischemia should be of prime importance. The last case, a 46-year-old male, old anterior wall MI, dyspnea on class 3, ejection fraction 20%, Holter showed no arrhythmia. This patient had only class 3 symptom, had old hit and run MI with ejection fraction 20%, large scar, EF of 20%. Whether this patient would benefit from ICD, that is the question. So as per the classic criteria, that is MADIT, CUT-HF, in all these trials, it is clearly indicated. All had shown benefit and must also had shown benefit in 40% of the ejection fraction with inducible sustained VT during an electrophysiologic study. All these trials have shown significant reduction. You'd be surprised to know that in some of these trials, which are guided by EP study and including MADIT2, the number needed to treat was quite low. Number needed to treat was less than 10 in 3 of these trials and within a period of 3 years. So it is a good response, significant reduction in mortality if you identify the correct treatment. And largely this is the recommendation, though there are some variations across the societies. LV ejection fraction less than 35% despite more than 3 months of optimal JDMD with the class 2 to class 3 symptoms. Ischemic, it is clearly indicated. Non-ischemic, it's 1A, 1B. It's generally it's all class should be considered as class 1 indication. Less than 30% despite more than 40 days optimal GDMD. This is a MADIT2 subgroup. Ischemic, it is class 1B and class A guidelines. But these are the subgroups one should consider for ICD when you consider a primary prevention. Ejection fraction has got a limitation. It's a dynamic variable. It's subject to intra and inter-observer variability. Preload and afterload dependent. As I mentioned, the majority of patients who experience sudden cardiac death do not have a very low EF. Not all patients with a low EF experience SCD, and only 35% of the patients in MADIT trial received appropriate ICD therapy. But of course, many of them could have been life-saving. So in India, there are many challenges: financial constraints, lack of reimbursement, lack of awareness amongst physicians, lack of innovation for referral, insufficient service providers. In India, the less than 2%, actually the penetration is less than 3%, 2 to 3%. The 10 million deaths, if 10% of the sudden cardiac death probably occurs in conditions that are guideline indications for primary prevention. So at least 1 lakh deaths. And if you calculate, that is 5,400 overall ICDs, and the penetration is less than 3%. So overall, less than 5% of them would qualify. They get ICD for this indication. So there are some studies like Improve SCA trial, which looked into some additional factors that could gate even in primary prevention, so-called 1.5 prevention. NSVT, frequent VPC, ejection fraction significantly low, less than 25%, with some pre-syncope or syncope. They benefited definitely with the ICD. So that is also important. And also look at certain other guidelines where they have shown that age less than, you can stratify this subgroup. Age less than 75 years, smoking, family history of SVD, and NSVT with significant scar. All these patients would benefit from ICD more than the other subgroups. So coming to my last but one slide. One should remember that ICD is not a public health tool. So it's a device designed to improve mortality in a particular individual. It's to make it more cost effective. To make it more cost effective, we need to identify who would benefit most. Individuals like, as I mentioned, as 1.5 can be taken into, or those who would have number needed to treat less would be taken into consideration. And timely medical therapy to prevent adverse ventricular remodeling appears to be very important. This is subgroup. So which are the scenarios where ICD is contraindicated? As I mentioned, severe comorbid illness, life expectancy less than 1 year, within 40 days of myocardial infarction and 90 days of revascularization, chronic kidney disease and ESRD, elderly, underrepresented in trials, in NVH class for heart failure. So concluding, this transvenous ICD has been in clinical use for more than 3 decades, and the robust data from high quality RCT support its potential benefit in SCD prevention in various patient populations. But we should remember that the benefit of ICD is not uniform, and risk stratification and improved patient selection is critical, especially in countries with limited resources and increased risk for non-SCDs. Thank you.